Hello and welcome everyone to our latest presentation on prophylaxis in COVID-19. Antimicrobial prophylaxis in mechanically ventilated COVID-19 patients is being used very commonly. It's mainly to prevent secondary bacterial, virals, and even fungal infections. The most common antibiotic that is used is beta-lactam. It is mainly to cover the community co-infections. We use vancomycin and linezolid to cover for the MRSA and the PRE. Meropenem or colistin is used to cover for the ESBLs and CR. Antifungals are mainly used for aspergillosis and also sometimes for candida. Gangcyclovir, as we have discussed in the previous video, it is mainly for the CMV reactivation. Finally, we have Septrin for Pneumocystis jirovecii. Now, the prophylaxis is a part of the spectrum of preventive prescribing. This is to prevent bacterial infections in COVID-19 pneumonia. Now, this can be done at various levels. The first is at the time of intubation. This is the potential pathogens that are already present. So you give a prophylaxis for the community organisms. These are mainly Streptococcus pneumoniae, Haemophilus, Neisseria, and again with the use of these antibiotics and the endogenous organisms, they tend to get increased, so there is an increased respiratory colonization. So in patients who are at high risk, especially those who are immunosuppressed receiving high dose steroids, there is a tendency to use preemptive or prophylactic antibiotics. This is mainly to again cover for the organisms like Klebsiella, Enterobacteriaceae, Pseudomonas, Acinetobacter. Now, the next is when you actually have some inflammatory response seen, and this is called a low threshold empirical. So here you do not really have a clear-cut sign that the patient definitively has a nosocomial infection. You have some inflammatory mediators which suggest that there is a possibility of a respiratory infection. Now, these indicators may be CRP, raised WBC count, procalcitonin, or fever. And in terms of gram positive, Staphylococcus aureus is something which can be causing infection at any of these levels. Now, if you look at the evidence that is available till now, there is very little evidence of using of prophylactic antibiotics. The only prophylactic antibiotics that have been used till now is the use of SDD and SOD, that is selective oropharyngeal decontamination and selective digestive decontamination. In selective oropharyngeal decontamination, we use non-absorbable antibiotics like tobramycin, colistin, and amphotericin as a pest to apply in the mouth and oral cavity, so that we reduce the load of the bacteria in the oral cavity. In selective digestive decontamination, along with this, we add an intravenous antibiotic, especially a cephalosporin, to reduce the load in the gut as well. Now, the use of this has been shown to reduce some infection and produce some mortality benefits. Now, most patients who are likely to be ventilated for more than 48 hours probably do receive some antibiotics at any point of the time, either before or after the intubation. The main causes are because these patients already had some major surgery, or they had out of hospital cardiac arrest, or they are suffering from sepsis, or they have a trauma, burn, or they have an immunosuppression state or acute organ injury. So presence of any of these condition usually tends the clinician to prescribe some sort of a prophylactic antibiotic in these patients. Now, if we look what is the guidelines in terms of influenza that is available, in terms of influenza, the common co-infections are again Streptococcus and Haemophilus, rarely being Staph aureus and Streptococcus pyogenes. So according to the guidelines, in patients who have suspected or confirmed influenza, if they present in a very severe state, that is having extensive pneumonia, respiratory failure, hypertension or fever, we should start antibiotics. And we should also start antibiotics even if the patient is showing initial improvement and then slight deterioration. Now, these are strong recommendation in spite of any randomized trials. Is mostly based on experience and strong clinical opinion to use of this therapy. Now, if you look in terms of surviving sepsis campaign, in terms of mechanically ventilated patients in COVID-19, they suggest to use empirical antibiotics. Now, this is a very weak recommendation. And as you can see, the panel suggests empirical antibiotic on the basis of superinfection in reasonably common in population, and it may lead to substantial increase in mortality. So, according to them, it is better to give antibiotics because the patient is intubated, the patient is having a severe viral respiratory infection, and last but not the least, because it is a pandemic, and pandemic is definitely has affected the quality of care that is being given, the nursing care, and the preventive measures that are implemented to prevent nosocomial infections are not properly maintained. It is difficult to maintain in such high patient loads as well. Now, if we look at the data that has, this is from UK, here you can see that there are spikes. This is the first spike and this is the second spike. In the first spike, you can see the green line. These are the nosocomial infections or the VAP. So as the number of infections increase, the nosocomial infections also increase. Now this is, as in you can see in the middle portion, the incidence of nosocomial infection is also low as the incidence of COVID-19 decreases. Now, as you can see in the top diagram, if there is just one COVID-19 patient, it usually is not associated with a high risk of ventilator associated pneumonia. However, when the pandemic and the caseload spikes in the same ICU where I previously had 10 beds, I'm having to accommodate almost 20 beds. And in this kind of a situation, patients, sisters and nurses and doctors, they're working in a not a very comfortable environment, wearing PPEs, which reduces their capacity to use the measures that are commonly used to prevent these infections, especially the infection control bundles and parameters. So this results in increased MDR organism transmission, decreased capacity of the patient, especially the staff, the environment, both are not adequate for giving proper care. And obviously with the PP, it becomes very difficult. And since these patients have an increased risk because they are on steroids, tocilizumabs, they have abscess, pneumothoracis, pulmonary embolism, bronchopleural fistulas, increased ICU stay, all of these are increasing the incidence of ventilator associated or hospital acquired pneumonias in COVID-19 patients. Now, if you look antimicrobial prescribing, in this study by Rowan et al., they looked at 18 studies for antimicrobial prescribing in COVID-19, and in this they found almost 8% incidence of bacterial or fungal co-infection at the time of admission, and 72% of the patients did receive some sort of antimicrobial prophylaxis at the time of admission. Now, this was more commonly used in patients who were admitted to the ICU and were undergoing invasive mechanical ventilation. Now, if we compare this data in terms of the other corona infections that we have had, it is significantly more, because previously in the old data, we can see that it was used only in 13% and 31% in the SARS-CoV-1. Now, as we said, since the SARS-CoV-2 is evolving and there are a lot of therapies being used, especially immunosuppressive therapies, these could affect the increased use of antibiotics. And also there are new variants, prior immunity also affects the severity of the disease. Now, this is a study from Italy by Gracilis et al. In this, they included 8 hospitals from February to May 2020. They did not use any selective digestive decontamination or any routine prophylaxis, and they found the incidence of ventilator associated pneumonias and nosocomial CRBSIs was 47%, and the incidence of multi-drug resistance was almost 40%. They had 17 cases of pulmonary aspergillosis and invasive candidiasis each. And one of the reasons they found for this was early broad spectrum antibiotic usage reduced the hospital acquired infection rates. This, as we have already discussed, this is especially true because of the environment and the caseload. Now, if we look in terms of epidemiology and microbiology of ventilator associated pneumonia, this is a French study of 188 patients. They had around 78 males and they had a mortality rate of 30%. The initial therapy, almost 90% received empirical therapy, with 80% with third generation cephalosporins and 12% with amoxiclav. 11% had co-infection at the time of admission. Respiratory sample taken at every 12 days showed 141 VAPs, in this case almost 49% of the patients, and the median time to VAP was 10 days. In this they found Enterobacteriaceae as a major contributor, almost 50% by Enterobacteriaceae, 15% Pseudomonas, MRSA 14%, polymicrobial was 14%, and Aspergillosis 3%. So as we can see, multi-drug resistance was again almost 60%. So based on all the data that we have and the previous guidelines based on influenza and the surviving sepsis guidelines of COVID-19, what should be the recommendation and how should we go about giving prophylactic antibiotic in COVID-19 patients? Now, should I use antimicrobial prophylaxis in mechanically ventilated COVID-19 patients? On admission, if the patient is on ventilator, then yes, you should use, because there is sufficient evidence that severe disease at the time of admission is usually associated with bacterial co-infection. So there is always a good practice to give a short course of antibiotics to cover for the community organisms. And also, since the patient is going to receive a lot of immunosuppressive therapies, it is better to go for some sort of prophylaxis. Now, during intubation, if the patient is already in the hospital, then maybe no, because there is no evidence that giving an antibiotic at the time of intubation is going to prevent your nosocomial infection. But do have a very low threshold for starting empirical antibiotics, especially if the patient is having a raised TLC count or patient is developing some sort of fever or non-improvement. Then we can suspect that there is a VAP, and we can cover for the Klebsiella and Pseudomonas. Now, it is better to give empirical antibiotic based on your local ecology. And regarding antifungal prophylaxis, it is better to avoid them unless you have a sufficiently clear evidence that patient is suffering from fungal pneumonia. Thank you for your patience and check our website for further information.